Very much. I would like to welcome Dr. Ricardo Vallejo to the podium. He will talk about Does Size Matter? The Basic Science of Radiofrequency Lesioning. Dr. Vallejo is affiliated with multiple hospitals in the area of Bloomington, Illinois, such as the Advocate Pro Mann Medical Center and the Advocate Condell Medical Center. He is in practice since more than 20 years. Welcome to FSIP 2019. Thank you very much.
Thank you. Thank you for making me feel old. Yes, it has been more than 20 years doing it. And I thank Harold and all the educational committee for bringing me here. It's a pleasure to be back in Miami. That's where I originally trained when I came to the country. My disclosure, I'm only presenting a commercial disclosure that in some way may bias my presentation. I want to be clear that any presentation that I made obviously has my opinion and therefore is biased, just by definition. The other disclosure that I have to say is that despite most of my research is in basic science, at the end of the day, I have to face my patients. And because of that, I think it's very important that we understand where we come from, because it doesn't matter what anybody tells us in terms of biases about one particular product in the market. We are the ones that face this patient at the end of the day, and therefore we have to do the best for them. I want to start by a story. So let me tell you a little story. There is this group of guys that happen to be physicians that for many, many years dreamed about the option to help older patients with this magical treatment. It was called radiofrequency. And everybody really believed and applied this therapy to their patients to try to improve their quality of life. Suddenly, though, the reality came back. And somebody decided to publish a study in which they concluded that the use of radiofrequency is not supported in the treatment of chronic low back pain, and it could be reserved only for research purposes. That's quite an statement after this study. But you have to agree, though, that the design of the study was extremely good. There were thousands of patients that were screened. Each one of the arms within the study had more than 200 patients, so it seems like a perfect study. So what do you do with that? I mean, suddenly our fairy tale is gone. Somebody goes in a major journal and publishes that what we have been doing and we have been believing in is not really true. And you can later on analyze the data and say, oh, you know, the diagnostic criteria wasn't good. They only did one diagnostic block. 72% of the patients responded to the diagnostic block, which we know not 70% of the patients with low back pain have facet joint or sacroiliac joint pain. You can criticize where the needles were placed, the size of the needles. There is a lot of things that you can criticize, but the article is out there, and we have, as physicians, not produced anything better. What is really interesting is the principles of physics are pretty much the same. So how is it possible that for so many years with this excuse that we have, oh, you know what, medicine is an art, because of that, everybody's doing whatever they want, and when somebody does it in a different way, then we all say, oh, what happened here? So let me go back to the principles. Let me try to discuss what are the principles of radiofrequency and how any of you can improve the outcomes by using these principles. And tomorrow I'm going to continue this same path of presentation talking about neuromodulation, but we have to stop being technicians, just only putting needles the way that we are told to do. So which are the challenges of radiofrequency? One is the variability in terms of the size of the lesion that we create. And guess what? The human body is quite complex, and the anatomy and the location of these nerves is quite variable. We did a study a couple of years ago in which we showed that the anatomy for the sensory nerves for the so-called geniculate nerves is totally different from one individual to the other, and even more, is different between one knee of the same individual to the opposite knee. So this is one of the challenges. The nerves that we are trying to target are extremely small, and as the patients aged, it's very hard sometimes to look at these landmarks that we have to use for our procedures. Similarly, previous surgeries, for example, can significantly affect our vision of the targets that we want to create. This is a reflection from Bogduk back in 1987. Even the modification, I'm quoting him, even the modification of the technique will require that the electrode, when you are doing radiofrequency, must lie within 1 to 2 millimeters of your target for maximal efficacy. That means, I don't know you guys, but you should be really, really good at putting the needle where you want. Otherwise, you are not going to get the results. Obviously, placebo is a factor, but otherwise, you are not going to get the results that you are expecting. 30% of the patients that you are applying radiofrequency are very unhappy with the results. 30% is a large number. These patients are going to go out and they're going to be quite upset with your therapy. Why? Because you did 2 diagnostic blocks, then you did the final amazing treatment and it didn't work. So why is that? I will argue that the main reason, and this is another disclosure that I have to give you. I didn't put the title about size, so I apologize for that, but I think it's quite interesting. Something that you have to think about is that when you are using a small size needle, you are using, for example, a 22 gauge needle, the radius, the volume of your lesion is not going to be any bigger than 200 to 300. Because of time constraints, I'm not going to ask all of you, but I question how many of you are using 0.25 milliliters for your diagnostic injection of local anesthetic. I frequently do that, and I'm very surprised that people apply 1 cc, 2 cc's. Do they apply steroids? Maybe a little bit, just in case. You want the patients to leave the practice and be happy. Who cares about this confusion? But you have to understand that if you use any volume larger than just 0.2 milliliters, the radiofrequency lesion that you're going to create afterwards is not going to match the original area that was numbed during your diagnostic test. In other words, you are not tricking the patient's mind, you are tricking yourself, because you are doing 2 blocks and then the lesion is not going to reproduce the diffusion of this volume that you applied. So please, if there is something that is worth for you, is do a right selection of your patients. Avoid tricking yourself, putting large volumes or putting steroids, because then the patient is going to be upset. 30% of them are not happy after your therapy. Look, also another challenge is the anatomic variations. If you think about the cervical spine, probably one of the best studied areas for radiofrequency, there is a lot of variation. Most of the cervical joints have only 1 branch, but there is 2 medial branches at C4 in 27% of the cases. C5 has 15% of the cases, 2 of these medial branches, C6 2%, and only 1 at C7. The diameter of these nerves in the cervical area is as small as 1 millimeter. So if you think you're going to target a 1 millimeter nerve with a 1 millimeter to 2 millimeter radiofrequency volume, it's going to be quite challenging. Again, it's amazing how good do we do if we don't follow the right principles. If you think about another challenging area, the sacroiliac joint, and that was recently published by Roberts, you can evaluate where is the location of the nerve, extremely variable, but also which nerves are the ones that innervate the sacroiliac joint. I was back in Boston when we did the first study on radiofrequency of the sacroiliac joint, and we consistently did L4 medial branch and L5 posterior primary rami, but those nerves only contribute in 8% of the cases for the innervation of the sacroiliac joint. In the other hand, S1 and S2 have to be always targeted if you want to obtain good reliefs. S3 in